everyone. I'm sorry for the delay. We had some technical complications here, but I'm very, very pleased to share with you that we are going to have Professor Roni Rosenfeld present us on, he's going to share his screen and he's going to share his talk on really forecasting epidemics and pandemics. So let me just tell you about Professor Rosenfeld. He is studied math and physics at Tel Aviv University, and then he did a PhD and a master's in computer science at Carnegie Mellon University. I had the pleasure and honor of being his colleague in our PhD at Carnegie Mellon. And currently, Professor Rosenfeld is the head of the machine learning department at Carnegie Mellon. So after he finished his PhD, he became faculty like I did. So his path and mine are very similar. The emphasis of Professor Rosenfeld's research has always been in machine learning, and also in particular, also in speech and language technologies. And he has been part of the machine learning department and the Language Technology Institute for many years, probably more than 20 years. I'm very pleased to tell you that Professor Rosenfeld is going to share with us a very compelling research on this problem of using machine learning on tracking and forecasting epidemics. And he has been doing these in several contexts before the COVID. But now the interesting results that he's also going to share with us are the results that he got with this particular data and this particular crisis we are facing now. So it's a very, very timely conversation with Professor Rosenfeld. Just to finish, he of course has many awards, and please look at his vitae that we shared, but he's a recipient of a very dear to our heart award, which is the Allen Newell Medal for Research Excellence, given by at Carnegie Mellon in memory of Professor Allen Newell, who we both knew very well, and he's one of the founders of the field of AI. So, Roni, it's a pleasure to have you with us, and please share your thoughts with the group. And we all look very much forward to do this. So let's plan on a talk of the time you want, and then we have some time until 11:30 a.m. for asking questions to Professor Rosenfeld. Thanks a lot, Roni, and welcome to JPMorgan.
Thank you, Manuela. Can you hear me okay?
Yes, we are perfect.
Okay. Thank you for this very, very generous introduction. I think my most noteworthy award is being an FOM, a friend of Manuela. I don't think you shared that we arrived at Carnegie Mellon at the same year and have been through the PhD program together. So that's a really bonding experience.
So do you want to do in slideshow?
I can.
Yes, I think it's there we go. Oops.
Oh, it's coming.
Yeah, there we go. Thank you.
Very good. Okay. All right. So the title of my talk tries to convey a story. And the story is that we have been forecasting epidemics for 8 years, but have been forecasting pandemics for only a few months now, and doing it in a hurry and in a scramble. And I'll explain that a little more later, but this is why the pandemic part is sort of hastily added for obvious reasons. For the last 8 years, since 2012, we had a research group called the Delphi Research Group that my colleague Ryan Tibshirani and I co-founded, and it was a typical academic research group. A few PhD students, maybe a few master students, occasional undergrad, and we were working on forecasting flu, dengue, a few other diseases. And then I used to say that I'm not going to get involved in forecasting a pandemic because I don't think it can be done. And then the pandemic happened, and I was kind of forced to change my mind and to find ways to do it anyway. So I will tell you the story in more details. The people you see in the line in the middle are the original members of the Delphi Research Group as of January. And the people you see at the bottom are all the people who joined us since then to scramble to do like a little Manhattan project for our for COVID. We had a tremendous number of volunteers. In fact, there are many more people who volunteered who we could not accommodate. This group is together about 30 some people. By now we're close to 40 and we're still growing. Our biggest challenge is, how to grow so fast without falling apart. I used to spend a good bit of time in my talks convincing people that epidemics are important, serious, have to be considered carefully and planned for. I don't need to do that anymore. I needed to explain to people why forecasting is important. I don't think I need to do that anymore either. So I cut out a lot of the explanations, but there are a few things I still want to show you, and this is one of them. This is infectious disease mortality per year since 1900. The peak that you see here, do you all see my cursor?
Yes.
You see my arrow?
Yes.
Okay. The peak that you see here is, of course, the 1918 flu pandemic. The other thing to notice here, of course, is that there has been a persistent decline in mortality from infectious disease over the century due to wonderful inventions like vaccines and public hygiene and other measures. This improvement kind of dropped to almost nothing starting in the 50s, 60s. And then something very worrisome happened. Things started getting worse, starting in the 1980s. Mortality all over the world, including developed countries, started going up. And in fact, that trend continues. This goes up to about 2000. The trend continues on here. And of course, we don't know what we're going to see here. We know there's going to be a blip. It will not be as high as the 1918 blip. We're fairly confident of that. How high it's going to be is yet to be seen. But the take-home message here is that epidemics and infectious diseases are not only a problem now with COVID. Even when we manage to bring COVID under control, or even if it went away tomorrow, it is still a significant problem that kills many, many people. I mentioned epidemics and pandemics, so I should probably explain the difference between them and why it makes a difference. If you look at the definition of epidemic in the dictionary, you will find many different definitions, but a common one is a rise in the prevalence of a disease or a condition. Usually we mean a rapid rise, and it's something that happens over periods of weeks, sometimes days. In some epidemics like HIV, it would be over years, so the pace can change, but usually we mean a dramatic rise in the prevalence of a disease. And if you look at the definition of pandemic, it says epidemic that spreads globally. That's where the pan part comes from. But that doesn't really capture what we mean by pandemic. It's really not what we use the word pandemic to mean. Really what we mean in practice when we talk about pandemic versus epidemic is a pandemic is an epidemic driven by a new pathogen, a new virus, a new bacteria, a new parasite, most often a new virus. And the reason that it's new, the reason that it's being new is important is twofold. One is there's very little known about it. So you cannot easily bound the potential damage from it. You cannot bound the risk. You don't know enough yet. When flu comes around, even if it's a new strain of flu and it spreads a pandemic strain of flu, we kind of know flu. We know what it can do. Even a 1918 flu, which was quite unusual, we have a sense of the bounds on how bad it can get. When you have a brand new pathogen, all bets are off. It could be a lot worse. Could be orders of magnitude worse. And there's nothing really in the science or in evolution that guarantees that it won't happen. The second important factor about a new pathogen is that the population has pretty much no pre-existing immunity against it. This is important because pre-existing immunity exists for almost all diseases that we've seen before, and even those that are pretty serious like flu. The reason flu only affects about 10% of the US population every year is because of pre-existing immunity. And every couple decades, on average, we get a new type or new subtype of flu that is we call it a pandemic strain, and it doesn't, the pre-existing immunity against it is not as high as it is every year, but it's still in existence, which is why only maybe 30-40% of the population would get it. I'll give you an example. The 2009 H1N1 pandemic affected about a third, or touched or infected about a third of the US population, and about a third of the world population, higher among children, more than 50% among children. So even though it was a pandemic, it was somewhat modulated and mitigated by the fact that it was flu. When you get a completely new pathogen, you may have to burn through 60, 70, 80% of the population before pre-existing immunity brings it to the level of a sort of a steady state, an endemic level. In the case of COVID, the inherent infectivity of COVID is such that if we didn't do anything to protect ourselves against it, if we continue to behave as normal, it would blow through, but it will not go away until it infected about 75% of the population. Given that we're all much more careful now, and that we've implemented many sort of spontaneous measures, we don't shake hands, we don't hug and kiss anymore, we don't get too close to people unnecessarily, that number might go down to 50%, perhaps even 40%. So it's the novelty and the pre-existing immunity that determines how many people it will have to burn through before it goes away. Benefits of epidemic forecasting or pandemic forecasting, I'll go through them quickly because you're probably familiar with many of them. There are multiple potential stakeholders and beneficiaries: governments, healthcare industry, and individuals. I would add large organizations as well. With governments, one of the most important things that a government can do is coordination and communication. If you think about CDC, we tend to think about it as the public health agency of the nation, but really it isn't. Public health law in the US is such that the CDC has very little authority. The vast majority of authority making decisions resides locally within counties and states, sometimes within school districts. CDC has very little authority, perhaps none, but it still has a huge role to play, and that is the role of collecting information, analyzing it, sort of recommending various measures and procedures, and communicating them effectively to the local public health officials, to healthcare providers, and to individuals. The timing and focus of communication is extremely important. A large part of the CDC is devoted to communication strategy. A large part of what they do under normal conditions is communication. Beyond communication, there are antiviral policies, school closure decisions, as I mentioned, they're local, and in some diseases, active measures like mosquito controls. I'll say something about mosquito controls. I know you may be eager to hear about COVID, but we're in this for the long term. We're thinking not just about COVID and flu, we're thinking about most infectious diseases around. Many infectious diseases in the world, those who contribute the most to mortality are vector-borne. That means they're transmitted by mosquitoes. There used to be ways of controlling against them by spraying. Let's take dengue, for example. Spraying has become less and less effective. The only currently effective measure against dengue is a very human-intensive measure of going door to door, looking for standing water, looking for holes in screens or lack of screens. You can do that, it works very well, but you cannot do it large scale on the entire city or entire country, not even an entire large city. You have to do it locally. So forecasting where the outbreaks will happen is as important as forecasting when they will happen. If you think about healthcare providers, here the benefit of forecasting is huge. At the height of a flu season, a typical flu season, about 15% of beds in hospitals are taken by flu patients. You probably know that hospitals in the US do not like to stand idle. The economics of healthcare is such that they need to stay almost fully occupied. So if you're going to get 15% of your beds all of a sudden taken by a rapidly moving epidemic, you want to know about it. You want to maybe cancel some elective surgery. We all know about that for COVID. But this is things they've been doing every year, except with very, very little notice. You want to worry about your staffing, about scheduling of vacations, repositioning of equipment. I used to have to spend a lot of time explaining these. I think all of these have now become household words. And then my favorite, well, before I get to my favorite stakeholder, which is individuals, I should mention that large organizations like jpmorgan also have a stake in forecast. Organizations that employ tens of thousands of people or hundreds of thousands of people who move them around the globe. It's vital for their sort of internal intelligence to know what the health risks are and when are good times to do that. I'm also thinking of militaries where it's crucial to know what problems may be expecting you in different places. And back to my favorite stakeholders are individuals. If you have a mother or grandmother who is old, maybe over 80 or even over 90, flu and in general infectious diseases and COVID are particularly dangerous to them. So if, again, imagine yourself post-COVID, you have a flu season coming, flu showing up every year, but a flu season may be very wide. It may be many, many months over the winter, but flu epidemic itself is actually quite narrow. It lasts maybe 8 weeks or so. If you know that the flu epidemic is arriving in your city in 2 weeks, you may want to advise your grandmother or mother-in-law, whatever it is, to stay put, not go to the mall. If she wanted to go travel, visit her sister in Cleveland, and you know that Cleveland is in the middle of its peak now or is about to be hit by a peak, maybe she wants to change her behavior. It may not affect you personally, but people who are in the high-risk groups would benefit greatly from having a heads up. I should mention the other high-risk groups. For flu, there are 4 typical high-risk groups: the very old, the very young, children under 6 months old, pregnant women, and people with immunodeficiency. The high-risk groups for COVID, you probably heard them. The very old, very similar profile, age-dependent profile to flu. The very young does not seem to be at a particularly higher risk. Pregnant women also do not seem to be at a higher risk, although we've yet to see what happens to babies who are born to such women. That's still to be seen. And immunodeficiency is a factor in COVID, as are a few other things, especially cardiovascular diseases, obesity, diabetes, COPD, and so forth. So there's a whole range of high-risk conditions for COVID that do not seem to be implicated in flu. Tell you a little bit about our research group. We were founded 8 years ago, as I mentioned. My colleague Ryan Tibshirani, who is also a member of our machine learning department as well as statistics, and I founded it in 2012. Our vision is to make epidemiological forecasting as useful as weather forecasting to governments, healthcare industry, other institutions, and the public. Our method of operation is by releasing all of our code as open source, releasing all the data that we process and create to the extent allowed by our sources, releasing all of our tools, and most importantly, releasing all of our forecasts publicly in real time. I might want to skip this. This is a bit about the development of the research community and the realization that epidemic forecasting is a reality. If you go back, I'll just mention a few things. If you go back to 2012, almost nobody was talking about forecasting epidemics. There's a tremendous amount of work on modeling epidemics. So that goes back more than 100 years now. There's a very, very rich theory, a mathematical theory of epidemics. What people have not tried until this past decade is to actually create a technology, create something that forecasts and gives you statistical bounds and guarantees and sort of putting it. It's a little bit like studying the science of meteorology versus creating the technology of weather forecast. We advocated for that back in 2012, wrote a white paper. We weren't the only ones. There was another group who did it out of Colombia. In 2013, the CDC got into the game as well. Maybe we had something to do with it. Maybe they were doing it on their own, but either way, they were a major mover. They announced an annual competition to forecast flu in the US. They were followed a year later by DARPA running a competition to forecast chikungunya. A year later, the White House Office of Science Technology Policy ran a competition to forecast dengue over 5 years. The DARPA and White House competitions were one-time events. The CDC became an annual event. The number of groups participating kept growing. The first competition, there were, I think, 7 groups. By today, by last year, there were close to 40. By today, we have many more because of COVID. The other thing that's worth mentioning here is in 2019, the CDC designated 2 national centers for flu forecasting, which have now evolved to be national centers for forecasting in general because we've included COVID in it. Our group became one of these 2 centers. The other one is at the University of Massachusetts. Let me go for one more slide and then stop for some questions. When we talk about epidemic forecasting, there are actually many, many types or flavors of forecasting. The first one is forecasting pandemics, namely those events that are new based on a new pathogen. And as I mentioned, we know very little about them and the risk bounds are very, very broad. We don't know how to quantify them. And most importantly, we don't have much data about them. This is the kind of forecasting that I stayed away from very, very adamantly up until January of this year. Within the alternative paradigm of forecasting epidemics, now you're talking about forecasting something that is somewhat periodic, not completely regular, otherwise there wouldn't be anything to forecast, but something that repeats and that you believe that past performance is indication of future performance. And that's where we put most of our effort in the last 8 years. Flu falls into this category, dengue falls in this category, many other diseases fall in this category. And within that category, you can think of forecasting across seasons. Perhaps the most important point with flu is what strain would dominate the next year so that you can formulate the vaccines appropriately. We may be in a similar situation for COVID if it mutates the way flu does. Or you can make forecasts within a season. And I'll focus here on forecasting within a season. That means the season has just started or is about to start. You may have a bit of information. Here in this case, the season is maybe a third of the way in. You still don't necessarily see the epidemic wave. You just know that it may be coming. But you're tracking it and you're trying to forecast when the wave will come, when it will start, how high it will get, how many people will it encompass when it's over, and when will it reach its worst time? So these are the kind of things you may want to ask. Within season forecasting, you can break into nearcasting, forecasting the next few weeks, longer term forecasting of the entire trajectory, but also maybe particularly interestingly is something we call nowcasting and backcasting. So nowcasting is simply the question of what is happening right now. And backcasting is the question of what happened in the last few weeks or since the beginning of the season. Now, it seems maybe strange that we would be struggling to understand what's happening now. This does not have a parallel in weather forecasting. In weather forecasting, it's very easy to know what's happening right now, easy scientifically. It took some work, but now there is a grid all over the planet, a 3-dimensional grid of measurement instruments that continuously send measurements from every point on the globe to central locations where it's shared across all countries. So knowing the present is not a problem. We know the temperature and humidity and wind conditions and anything else that's relevant all over the planet in real time. And as a result, we also know what happened in the past. In weather forecasting, you know the past and the present. You are free to focus on the future. In epidemic forecasting, you don't. Understanding and estimating what's happening right now and what happened in the past is still a very significant part of the problem. In fact, a lot of our work, I would argue more than half of our work, was on nowcasting and backcasting as a precondition for doing successful forecasting. That becomes even more critical in a pandemic, and I will get to that. So this picture tries to capture conceptually this notion that yes, there is a lot of uncertainty about the future. We're measuring in the y-axis here, there's sort of a very vaguely the notion of uncertainty, and that uncertainty grows as you move further into the future. But even in the present and even in the past, there is uncertainty. In fact, it never ends. We don't know with certainty how many people have any particular disease at any particular city, and we probably never will. Let me take a quick break here and ask if there are any clarification questions.
I think we are fine, Roni. We should go and take the questions at the end, okay? Thank you.
Okay, sure. I mentioned the kind of targets that we're typically interested in. How bad will the season be? Its peak intensity. When will the peak intensity happen? How long, and so forth. Let me mention briefly to the more technical people in the crowd the kind of metrics that are often used in measuring how good your forecasts are. Roughly, they fall into two categories. One is point prediction. You're trying to, quote unquote, guess or estimate the most likely outcomes. And then when you measure to the extent you can that outcome, when the time has passed, you measure things like your absolute error or your squared error and try to minimize those. A different kind of metric is applied to distributional predictions. That means we don't try to guess a single answer of what's most likely to happen, but we actually try to give you an entire distribution of how likely is each different outcome. And that's far more useful to governments and to other decision makers than just a point estimate. Because a point estimate does not convey to you your level of confidence. Two people can give you the same point estimate. One of them is extremely confident, the other one is not confident at all. If that point estimate turned out to be very, very accurate, then you could say that the person who was extremely confident gave you, in hindsight, you can say that they gave you a better answer. But of course, if it turned out to be off, the better answer was by the person who wasn't so confident. So conveying both what you think is going to happen and how likely it is to happen is extremely important for decision making. And this is where most work on epidemic forecasting is focused. I'll tell you a little bit about common approaches to modeling and therefore to forecasting epidemics. The first one is the one that you may heard about the most. It's called the mechanistic approach, also a comportamental approach. And the most famous example is the SIR model or SEIR models. That means that you make very simple assumptions about what matters. You assume, for example, perfect mixing of a population, that any person is interacting with any other person with the same probability, which is of course not true, no matter what unit you're using, state, city, neighborhood, family. It's never correct, but it's the assumption that's being made. And you keep track of how many people at any one time are infectious, how many people are still susceptible, that means they could be infectious, and how many people, that's the remainder, who are recovered or removed or resistant. This is the modeling method used by 95% of people who are doing modeling of COVID because it's very, very simple. It's easy to build and to track. It's intuitively very appealing, but it's not very good at making forecasts. The historical track record of the last 8 years show that models that were based on SAR performed relatively poorly relative to models. The reason our group is focused not on comportamental models. Let me pause for a minute. It says my connection was not good. We stayed away from SIR models. We are incorporating them a little bit into COVID modeling for reasons I'll describe later when we get to pandemics. The almost opposite of the SIR models are the agent-based models. Agent-based here does not mean what it means elsewhere in AI. It does not mean agents of the type that, say, Manuela's work is famous for. All it means here is individual level simulation. So it is also a mechanistic model in the sense that it tries to model the way we believe the dynamics of epidemics work. Namely, you have a simulation of many, many people. You try to build like a sim world, a model of the world with millions of people, and they live in households, and they go to work, and they go to school, and the households have certain distribution. Some of them are, 2 adults, 1 children, 2 adults, 2 children, 2 adults, 3 children, 1 adult. You try to match the reality of the location you're modeling. Same with workplaces, commute times. You really try to build a miniature real world, and then you infect, quote unquote, some of these people, and you watch them go to school, and there's some probability they will transmit it to other kids, or that the adults will transmit it, and there's transmission in the neighborhood. There's no limit to the details that you can put into such a model.
So can I tell you something? I think that some people may leave at 11 because of other meetings. Then though we stay half an hour more. I think that you want to give a demo. I don't know what
it is. I will move forward.
Sure. Might be better. I'm sorry for the beginning, but I
think problem.
It would be better.
Let me do that. All right, let me talk for 1 minute about nowcasting and then move to my demo, because the demo is a lot about nowcasting of COVID. This is a focus on the concept of nowcasting that we described before. And what we're trying to convey here is that the number of people who have flu-like symptoms is here, and it's not measurable, and it can come from many different epidemics. For example, one of them might be flu, the other one might be COVID, the third one might be some other virus. But what we do have access to is a variety of other indicators that we can measure, from which we can try to infer what the actual number of people with flu-like or COVID-like symptoms are. So a lot of our work is on expanding this line, on creating what we call sensors, which are measures of things that we can measure that we believe are strongly related to the latent number of people who have the infection, which is a prerequisite for doing the forecasting. Having said that, I will skip all the description of how we do nowcasting, maybe just to show you how the end result of how it works. The black line here is the ground truth, to the extent we're able to have it a year later or 6 months after the fact, when all the measurements are in. The colored lines are the different sensors. You can see that any one sensor is quite noisy. When we apply our method of sensor fusion, we get a reconstruction of the original signal in real time. To emphasize how important this is in flu and in the future in COVID, the black line is only known well after the end of the season, 6 months later. The red line is known in real time. So we basically managed to cut 6 months off of the surveillance process. Let me move to the pandemic, as Manuela suggested. Our approach to forecasting has always been a machine learning approach. That means not a mechanistic approach. The last slide I showed you talked about 2 mechanistic approaches, and the next 2 were machine learning approaches, which basically means we don't trust our understanding of how the pandemic spreads. We rely on data instead. This is a sort of a nutshell way of describing it. When you do that with flu, when you have at least 20 years worth of data, it works very well. Our methods have consistently beat all the other methods that used, including those that used the mechanistic approaches, because we had 20 years worth of data to train on. I mean, this is the story of machine learning. When you have data, you typically do better than a non-machine learning approach. The problem with the pandemic is that there's almost no training data. So under these circumstances, the mechanistic approaches have a huge advantage. They don't rely as much on data, they rely on stories, they rely on understanding. The way we compensated for that is by relying more on diversity of geographic locations rather than on time depth. We do not have much time depth. At this time we started this, we had 0 historical data on the pandemic, and by now we have a few months worth of historical data. What we do have is a lot of goodwill. Because of the conditions, because of the overall both anxiety level and eagerness to help, we had a tremendous number of volunteers helping. Equally important, we had a tremendous amount of data providers coming forward and offering us their data. I cannot emphasize enough how critical data is to our work and how difficult it is to get data that's relevant to epidemic and pandemic behavior. I have spent a good part of in the last 5 years, a good part of my work, professional time, seeking new data sources and convincing the owners to release them to us and negotiating the data use agreements. The other people who have a lot of goodwill at this time, are lawyers. So negotiations that took a year or two before were finalized in a matter of a week or two. So this has been a tremendous sort of boost and complement for us. So here's our strategy in approaching the pandemic. We could not build sensors in the traditional machine learning sense of sensors because we could not do supervised training of our different covariates or different sources of information. Remember, a classic machine learning approach is you have historical data, you have the true labels for the data, you run some kind of mapping, either regression or something else, that trains your model to go from your covariates to the labels that you have for the history. Well, we're in a situation, or we were in February, March, in a situation where there is no ground truth, and we didn't expect to have ground truth for at least 6 months to a year. So we cannot do supervised training, supervised learning. What we decided to do instead is unsupervised learning and build what we called indicators where we can show that they have significant information relative to the short-term future, because short-term, a week or two, we could wait, but we could not wait 6 months. So what I'm going to show you next is all the indicators that we developed that have been vetted and proven to be highly correlated on a time scale of 1 to 2 to 3 weeks with the evolving pandemic. The second decision we made for forecasting a pandemic is to focus on what matters in forecasting the pandemic. The thing that matters the most is forecasting demand on hospitals and on ICUs and ventilators. That was the case in February, March, and April. It's slightly less the case today. I think the bottleneck has been somewhat relieved, but it's still the case that most public health officials we talk to, the first thing they want is a forecast of demand on their hospitals. When you forecast demand on hospitals, you have to realize that these hospitals do not serve just one particular local community. They tend to serve much larger community that spans many, many counties. For example, in southwestern Pennsylvania, they span an area of about 13 counties. These are known as hospital referral regions, and that's the geographic level at which we do our forecasting. And then we focus on about a 4-week time frame. The reason we chose 4 weeks is because any longer than 4 weeks we felt we could not validate and we could not realistically create accurate forecasts for. There was way too much unknown. Any less than 4 weeks, it becomes not so actionable. If you want to intervene in the pandemic, either by making the mitigation stricter or less strict, it will take 2 to 3 weeks for that to have an effect. So you need to have a little bit more of a heads up time. And I already mentioned we make up for lack of history with geographic diversity. And I will go to the demo now. So what you're seeing here, I'll switch to states, is our main nowcasting and eventually forecasting site. Right now, this page focuses on nowcasting and backcasting. So this is a list of indicators that we have developed from different data sources, some of them public, some of them not. Some of them are available at the state level, some of them are available down to the county level, and some of them are available at metro level. This is the picture of the United States as of here July 7th. We can move it to more close to now, July 18th. This happens to measure the percentage of daily doctor visits that are due to COVID-like symptoms. This is an important definition. This is technically known as CLI, COVID-like illness. It doesn't mean they have COVID. It means they have symptoms that are consistent with COVID. It is not as specific, but it is a leading indicator. And we have demonstrated a very high correlation between this measure and confirmed cases a week and 2 weeks later and deaths 2 weeks later. If you want to see, you guys are in New York, at least most of you are, you can zoom in on, first of all, New York State and look at how this measure was tracked over time. You can load a few more weeks and look at the entire story of the epidemic in New York State, or we can switch to metropolitan area and look at the history, which is probably all too familiar and painful to you, of the New York, New Jersey metropolitan area. You can see here the wave of doctors' visits in May, much later than the wave that you are familiar with of deaths. So you see there are some differences between symptomatic behavior and confirmed cases or confirmed deaths. You can switch to hospital admissions. Hospital admissions are a far more specific measure. Usually when you're admitted to hospital, either you already know that the person has been tested and confirmed as COVID positive, or it becomes confirmed one way or the other within a day or two. Switch to county view. You can look at the behavior of individual counties. I will go to my favorite county in Allegheny County in Pittsburgh. You can see we've had a reasonable history up until recently. Some areas do not have enough data to form a robust estimator, so we lump them together within the state. I'll show you a few more of the indicators. One of the perhaps most exciting indicators we have, or a set of indicators, comes from a survey that Facebook enabled us to run. So Facebook agreed to put our survey on their feed, on people's feed throughout the country. It's opt-in, it's optional, but quite a few people opt in. We get, I would say, about 70,000 responses a day. This is the percentage of people who respond positively to the question, does anybody in your household currently have any COVID-like symptoms, where we give them the list of COVID-like symptoms. You can see that percentages are quite low if you switch to state level. The percentages would typically be in the 1% to 2% level. You may think that's very small here. You know, in Texas, you have 1.2. But if you change the question slightly and you ask them, do you know anybody in your community who has COVID-like symptoms? The numbers jump to the range of 20 to 35. Both numbers are very informative, and they actually don't convey the exact same information. In other words, having both of these indicators gives you higher correlation and higher predictive power than having just one of them. The survey, I don't know, chances are if there are 300 people on the call, that several of you have seen these surveys. I hope you took them. They ask a lot more questions that we're still in the middle of analyzing. We also track people's mobility. This is from SafeGraph data. It's a company that makes their data available. And that's available again at metro area, county, and so this is a measure of how mobile people were at different times of the pandemic. You can see very clearly the stay home periods versus the more modern periods. What you're seeing here is weekly cycle. Google search trend is another source of information that was very useful with flu and is useful now. I know it's 11 o'clock. Manuela, did you want me to talk a little bit about the forecasting itself? Most of our work has been on nowcasting. We started doing our forecasting we started releasing our forecasting to the CDC about 2-3 weeks ago. We waited about a month. We took about a month of internal forecasting to track our accuracy.
So I think very good. Thanks a lot, Roni. So this is amazing. And does the tool also provide an ability to see your forecasting, or is basically an analysis of, or is an analysis of past data?
This website is past and current. This is up to date and updated daily. We have not released our forecasting publicly yet. The CDC asked us to give them our forecasting first. They're going to sort of vet it, and they're very, very sensitive to public display of forecasts. We will eventually make our forecast public, but not until we have, I would say, another 3 to 4 weeks of track record. So what we've done is our first forecasts were made about 5 to 6 weeks ago. We went through a period of 3 to 4 weeks of vetting them internally, checking prospectively that they were accurate enough. Then about 2 weeks ago, we decided they're good enough for the CDC. We started passing to the CDC. We submitted the last 2 weeks. And in about 2 more weeks, we will probably make them public.
Very nice. So let's thank Professor Rosenfeld and open for questions now. For the people that can stay with us half an hour more, we can in fact then delve into the forecasting aspect to see the technical details for the forecasting. Otherwise, let me take questions from anyone who would like to first ask questions about general studies on epidemics, and then this particular kind of like nowcasting ability that Professor Rosenfeld made available. Okay, so should we open for questions? Shane, can you give directions on how people should ask questions, please, or someone?
Ladies and gentlemen, please use the raise your hand feature located at the bottom right of your screen if you're using a computer, or in the top right if you're using an iPad. Your name will be called and the name it was received. If we do have a question from Rambir, please unmute yourself and go ahead.
Thank you.
Yeah, hi. Can you hear me?
Yes, Rambir, we can. Go ahead.
Yeah, so first of all, thanks for organizing things. This was good, even though in between I kept on getting messages from, work messages, but I tried to remain engaged. This was a good presentation. My question is, I have not heard of this forecasting earlier. The group. So when you mentioned that a lot of others are using it, and so till date, right, when the COVID was happening or around like between January and April or May, was there any government organizations using yours forecasting to prepare themselves? And what do you think in future? Do you think your forecasting is that good that in future, if there is similar epidemic, then it can be, you can let them know probably a week or 2 weeks in advance, and they can actually prepare better, because this time definitely we were not prepared well.
Thanks.
So, yeah, it's very easy to forecast. It's very hard to forecast accurately. So you've seen a lot of forecasts out. It's not hard to build an SIR model. In fact, there are probably hundreds of them online, and they can come online as early as February or March, right?
Right.
That's not what we do. What we do is build a track record and validate our forecast and give you not only a forecast, but also a confidence level. That takes time. We have been doing it for flu now for 8 years. And to answer your question, the CDC has been using our forecast for flu. They tested it for the first 3 or 4 years. In 2017, the head of the flu division, one of the largest divisions CDC, made a decision to start using our forecast for their operational use. So they started putting them on their website, and they started incorporating our forecast into their public.
I'm sorry, can I ask that everybody mutes themselves, or Rambir, maybe it's you, we are listening to typing. Thank you.
Yeah, I'm sorry.
They have started using our forecast in their operational work. They incorporated them into their public messaging. They incorporated them into the web. If you look at the web pages for flu forecasting for the CDC, you will find our forecasts there. So we've been doing that for several years now. For 3 or 4 years, they've been using it regularly, and they will continue to use it. Now, for the current situation, you can jump up and give a forecast in March or February, March or April. And by the time it's time to check it, probably will not be remembered anymore. What's really important to do is to create a track record of forecast so that you don't have to rely on whether the model was right or accurate or appropriate. You rely on the track record instead. This is what we've been doing slowly and surely. We're going to continue to do both COVID and flu in the next year and the coming years. We're here for the long term. Our center was funded for 5 years and will probably be renewed for at least 5 after that. So our focus in the case of COVID right now is on validating the forecast and making up to 4 weeks ahead predictions. This is what we feel we can do for the first time a pathogen comes around. As far as being prepared, I don't think you can be prepared for when a pandemic shows up. But once it shows up, you can start providing very, very near-term estimates of it. I think a lot of the things about being unprepared had to do with many other things, with protective equipment, with the testing and so forth, that I don't think we need to comment on here. Clearly, we could have done things better, but our focus is on creating sort of the long-term infrastructure and the long-term guidance at the local level.
Okay, so thanks for that. I just have a follow-up question. So one is that
Rambir, maybe we'll give a chance to someone else to ask a question, and then you can come back.
So okay, no problem.
Yeah. But hold on a second, Rambir. So,
yeah, no problem.
Just a second, okay. Are there any other questions, please?
Yes, Abhishek, mute yourself and go ahead.
Hi, this is Abhishek Trahan. I have a couple of questions. Basically, this seems more like nowcasting, as you're saying. Like when I look at the indicators, it seems like there's a strong positive correlation between them. So how have you, taken into consideration that factor? Because to me, it seems like it's giving same results for all the indicators, and there's a strong positive correlation. And second, can you talk a little bit more about like the unsupervised learning for any trend analysis that you're going to do for like future predictions, like what algorithms you have used on unsupervised learning?
Sure. So the indicators are correlated because they're all indicative of the same future behavior. We selected them to have high correlation with week ahead and 2 weeks ahead measurements. So in that regard, they're correlated, but there's also a lot of differences between them. And in fact, one thing I didn't show you is we created a combined indicator that combines many of these, which is for people who are not interested in the detailed view of the different aspects of things, but just want to see how bad things are. And what we did there is basically principal component analysis with some modifications because of the most recent data is not complete. It's subject to backfill or to revisions later on. That's one reason. Second reason is that the different measures are on different dimensions. But effectively, the heart of what we did in combined measure is the first principal component. As far as the differences between the different measures, I don't know how much you've looked on the site, but there are many places where they disagree. And that's okay. It tells you something too. The main use we see for this map is for local health officials. Remember, public health is done locally. And by local, I mean county, usually. So public health county officials typically are interested in the different aspects of the pandemic as they happen in their location. How many people are currently hospitalized, but also how many people are currently being tested? What is the positivity rate? How many people have symptoms but have not gone out to be tested? How many people have heightened awareness, maybe because of COVID in their neighborhood, and how many people know people in the neighborhood who have it, and so forth. And these may very much disagree with each other.
So how are you making sure that the results are not overfitted when you are combining various indicators?
Because we have not combined them. So we're not combining them for nowcasting, we combine them for forecasting. So for nowcasting, we did a principal component analysis, and we're giving you here the first component. For forecasting, we have employed two methods. One of them is a time-aligned regression. So we take the time series of cases and deaths in different locations, in different counties or in different states. We align them by their best fit of when things started picking up in each location. And then we use that with regularization, basically with lasso regularization, to make forecasts of incident deaths 1 week ahead, 2 weeks ahead, 3 weeks ahead, and 4 weeks ahead. Okay, that's the essence of our of the method that we have so far vetted. We have another method that's being vetted now, and we intend to combine them.
Okay, yeah, so maybe you can also send me, Roni, like a pointer to a paper that explains the technical details, because many people in the call are basically interested on the technical detail of the actual nowcast.
Sure, I was aiming my talk at a broader audience, but I'm happy to point you. We're writing up a blog post with the technical details of the forecasting, and we have the details of the nowcasting already online. So I'll point you to all of them.
That'll be great. Thank you so much.
Thanks a lot. Other questions?
Yes, Joseph, please unmute yourself and go ahead.
My question was around the confirmed cases. One of the key indicators is about, when we hit herd immunity, whether that's 50 or 75%, depending on how much we isolate. Currently, the confirmed cases are around about 4 million, but reasonably only a fraction of the real infected people are that 4 million. So I've heard estimates of roughly 10-to-1 ratio between confirmed and true cases. So do you have any indicators which provide insight into what's the true number of cases that are out there and how close we are to herd immunity?
Yeah, that's a wonderful question. Thank you. We have that in the pipeline. We don't have it yet because the only measure that we have that sheds light on that is antibody tests. And those are few and far between, but they're becoming more and more numerous. So as we have, the CDC has a plan that has already started of doing periodic measurements of same populations, so measuring their antibody levels over time. We will mirror them here and relate them to. This has been the biggest open question, right? The $64 billion question, or I would say $1 trillion question. What is the size of the iceberg underneath? And the number you quoted of around 10 is indeed a number that I am familiar with. There was a paper that just came out yesterday in The Lancet with some more information that shows significant variability between locations. So very different multiplicative factor in New York City, say, as in some rural areas. But it all is around the order of magnitude of 10, maybe 6 to 20 something. Herd immunity. New York might be close. So the consistent antibody measurements in New York are in the 20-some%. And that's, remember that the antibody testing takes 2 weeks. So if you're measuring it today, it's the state of the population as it been infected up until 2 weeks ago. And the measurements themselves were done in May. So we had 20-some% already in late April. By now, it's probably somewhat higher. The question is, what percentage would you need to get herd immunity? I mentioned earlier that we know if you behave the way you behaved a year ago, you would probably need about 70-75%, but nobody's behaving the way they behaved a year ago. So 40% might be sufficient.
Yeah, thank you.
Thanks a lot. Another question? We have time for a few more questions.
Yes, Sarab, please unmute yourself and go ahead.
Hi, Ronnie. So I have a question because when we are saying unsupervised learning, so you must have used different, and you have also used time series analysis. So was there any possibility where you, while doing a correlation analysis between different factors, vector analysis, I'm basically referring to vector analysis here. So what was the exact, deciding factor for you for, which particular parameter or which particular, dimension you would consider for under this, regression when you're looking back? Yeah.
Sure. So we used 2 steps. The first step was vetting of each information source. That was done in isolation, each source by itself. We considered many more. In fact, there are about 3 or 4 more that are coming in the next week. And there are more that we considered, worked on for a while, and decided to ditch. Our measure for that was correlation, 1 and 2 week ahead correlation with cases and deaths. Okay, that was the first step. Second step is how do you combine them? And here we had 2 subgroups, each working with slightly different methodology. The one that we have felt confident enough to put out and give the CDC starting 2 weeks ago uses L1 regularization. So we basically threw in all of the measures, all of the covariates, and used L1 regularization to choose among them. There's some variations among that. Some of the measures are more useful in the time shift, as you can imagine, than others. But ultimately, we didn't have to choose them. We basically use a regularizer to sort of push down on the number of covariates.
Okay, thank you, Ronnie.
Next question.
Charles, please unmute yourself and go ahead.
Hi, this is Charles. Thanks, Dr. Rosenfeld, for your wonderful presentation. I have a question regarding to the nowcasting, because I think one of the major challenges we're facing, when dealing with COVID, is this kind of super long, a 2-week long incubation period, plus, the number of asymptomatical like COVID patient. So from the scientist perspective, that is saying the data we're looking at probably is like 2 weeks old and probably underestimated. So I was wondering if there's any method we can adapt to make sure our model to tolerate this type of gap and uncertainty and provide the real-time guidance to people right now.
That's a great point. We've been struggling with exactly this issue. You can imagine what's called in epidemiology a severity pyramid. Imagine at the bottom of the pyramid is the whole population. A rung above it is people who are infected, whether or not they're symptomatic. A rung above that is the people who are symptomatic. A rung above that is people who chose to go to the doctor or the emergency department, so they are called medically attended. And then above that is hospitalized, and above that is intubated, and above that is dead. Okay, this is called the severity pyramid. In parallel with the severity pyramid is the time dimension, which is what you were talking about. When are people going through that? Of course, they start by being infected, and then on average 5.5 days later, most of them show symptoms. And then a few days later, some of them choose to go to the doctor, and some of them a few days later go to the hospital and so forth. So you can imagine that the bottom of the pyramid is the leading indicators, and the top of the pyramid is the lagging indicators. And what we have done very successfully with flu is combine all of them, where the leading indicators are in some sense the most informative, the most important for the reason you mentioned, but at the same time, they are less specific, because if somebody has symptoms, we still don't know if it's flu, or in this case, we still don't know if it's COVID. So as you move up in the time, as you lose time, you gain specificity. So your question is focused on the early stages, on the early indicators, and we put a lot of effort into that. Things like retail information, people buying thermometers, people searching the web for information is often a leading indicator. It doesn't solve the problem completely because we don't have any measurements of actual infection. The measurements we have start with symptoms, but it's still as ahead as we can get. If you are looking for measures of infectivity, you have to go and look at transmissibility. So these are these two measures. If you believe that people's mobility behavior as captured by Google and by SafeGraph, how much time they spend at work versus how much time they spend at home versus how much time they spend in places like malls and open places, if you believe that's strongly correlated with transmission, that may be by far your earliest leading indicator. So far, the data is very unclear about that. Part of the problem is that when people lock down, they still continue to transmit, except it's within the household. The way we ideally would deal with that is by having the cases broken down by, was it likely a household transmission or a community transmission? Unfortunately, we don't have that data yet. I hope that in the future that kind of data will be collected and made available. But it is a constant struggle, the timeliness.
Thank you so much.
Next, we have Gokul. Please unmute yourself and go ahead.
Thank you. Thanks for the excellent lecture, Dr. Rosenfeld. My question is on your backcasting, because backcasting is very popular and entrenched in finance. Given your weather forecasting analogy, what are you trying to do with the backcasting? Are you not trusting the data, and does it affect your nowcasting? Thank you.
So by backcasting, I do not mean prospective or in-sample forecasting. What I mean is trying to estimate as accurately as possible how many people were infected in the particular location at a particular week in the past. There is no ground truth. That's our biggest problem. There is no ground truth. Nobody knows, and nobody probably will ever know what the actual number is. The only way we can validate how good our estimates of past incidents is by, do they help us make better forecasts? Yeah, that's the proof is in the pudding. Let me show you an example where there is ground truth. Flu is very not sexy these days because of COVID, but we've worked on flu for a long time. So this is our nowcasting for flu. It's called ILI nearby. ILI is influenza-like illness. It's been around for 5 years now. What I want to show you is one particular chart. It also speaks to the previous questions. I think Charles comment on timeliness. Okay, it comes back, but it's not the one I wanted. Okay, so let me make it a little bigger. In flu, there is a very large surveillance network run by the CDC that collects information from doctors' offices, not from all of them, but from a large representative sample, and makes it available, but at a significant time delay. So information about flu for during a particular week is first reported at the end of the following week. And then it's revised a week later, and a week later, and a week later, and it's continued to be revised throughout the season until well after the end of the flu season. In June, July, the CDC finalizes all of the reporting and measurements and determines what is the official ground truth for flu for each one of the weeks of the preceding season. Of course, by that point, it's not very actionable. It's way too late, right? It's good for historical purposes, for analysis. And it's not really ground truth because we didn't really measure every person in the community, but it's much closer to ground truth than anything we have for COVID right now. So in this situation, we were able to do supervised training of the same models and the same kind of indicators. And what you're seeing here is the trade-off between accuracy and timeliness. The way you read this is the shaded week is the week in question. So everything here is about a specific week. And the x-axis is when you got the estimate. The first time the CDC has their own estimate is here, this square. And as I mentioned, it's available a full week after that week ended. And it's not very good. It's got a significant error relative to the final estimate, relative to the quote unquote ground truth. A week later, there's a revised estimate that the CDC gets that is significantly better. And then it keeps getting better and keeps getting better, but it doesn't get to zero until many weeks. What we were able to do for them is the following. We were able to give them an estimate that's almost as good as their first estimate, but almost a week earlier, as soon as this week ended. We were able to give them an estimate before the week ended. This is basically a forecast. It's happening on the second day of that week. We were able to give them an estimate a week before that and a week before that. So these are true forecasts, and you can see the trade-off here. You can see how as time passes, you get a more and more accurate answer. What we were doing for them is basically expanding the time horizon backwards to when they get the estimate. Now, this, you could argue, is not nearly as good as this, which is true, but it's already quite useful to them. It is very useful to them, even with a 0.5%. This is measured in percent, so this is about 0.55% error. It's still extremely useful for them to know it 4 weeks in advance or 3 weeks in advance relative to what they had before. We would like to do the same thing for COVID. The problem is not having the data, it's not having the ground truth.
Thank you.
Next, we have Alex. Alex, please unmute yourself and go ahead.
And this will be our last question. Okay. Alex? Can we try the next one?
Yes, Ritika, please unmute yourself and go ahead.
Thank you.
Hi, thank you, Professor, for this webinar. My question is for the fundamental corollary for predictions. So you said that the government didn't allow you to really put out predictions, but you do intend to give out the forecast. So if and when you do, for example, you would predict that 4 weeks from now in your forecast, the cases would go down significantly. But what if this information is public and people get overconfident and they started going out? So the forecast would cancel itself. So do you have that kind of fear, or and if you do, then what are the measures that you will take?
We do have that kind of concern. Let me just clarify. I did not mean to say that the CDC did not allow us to forecast it. We are free to forecast whatever we want. It's just that they asked us to provide them the forecast ahead of time for them to vet it with other forecasts and to combine it into an ensemble that they use in their communications. We decided we do not want to release it publicly until it's been vetted through that process. To answer your question, the question of when forecasts interfere with change reality, how do you deal with that? I call that a good problem to have. It used to be that you had to really convince people to listen to these forecasts. Now we have the opposite problem that they listen too much to these forecasts. They listen to forecasts that do not have a track record yet. People are so desperate to know what's happening to reduce the uncertainty and the anxiety that they listen to forecasts. And in fact, it's very dangerous, I would say, or problematic to release forecasts because it is almost guaranteed that they will be misinterpreted. For the reasons that you alluded to, that all these forecasts are done under particular assumptions of what the public behavior will be and what the government decisions would be. And when the decisions or the public behavior deviate from that, the forecast is really meaningless And yet people forget that. Even when you do a good job of putting the warning on the forecast, and many sites did not do it as good a job as they should have, but some did. And they said, this is only under these conditions. That's too much for people to remember and carry with them. People forget that. All they remember is the curve. So that's why releasing forecasts publicly in a time like this is really fraught with danger. Our goal has always been support to public health officials rather than the public. We do make what we do public when we can, because it's one of our target audiences in the long term. But for COVID, our decision was to focus on public health officials rather than the public for several reasons, but this is one of them. It's really you're asking for trouble if you release a forecast publicly.
So this is actually a perfect way to end with a very kind of like inspiring comment and a very excellent questions. Let's thank our speaker again, and thank you very much, Roni. It was a pleasure listening to this and amazing work. And I wish we could have, maybe we'll have a follow-up with papers for the people interested in further technical details. Thank you very much, Roni.
Thank you, Manuela. Thank you all.
Bye-bye. Thank you. Bye-bye. Bye-bye.
Bye-bye.
You can now leave the
Thank you.